Well, hello, Tachi participants. It's great to be back with you again today. We have a great presentation in line for you around health equity. And featured today is going to be Nadia Siddiki. She's Texas Health Institute's inaugural Chief Health Equity Officer, where she leads the Institute's internal and external health equity initiatives. Nadia brings nearly 15 years of experience designing, leading a range of national, state, and community level research, evaluation, and cross-sector collaborative initiatives addressing health disparities, the social determinants of health, and health equity. She earned a master's of public health and health policy and management from the University of Arkansas for medical sciences, and a Bachelor of Arts in economics with honors from the University of Texas at Austin. Go Horns. So we will hear a lot about equity today. You're going to hear more about it over the next 3, 4, 5 months, and Nadia and her team will be there to help you as consultants in this work. And we certainly look forward to an interesting presentation today from Nadia. Nadia, it's all yours.
Thank you. Thank you, Keith, for the kind introduction. And thank you to the Texas Accountable Communities for Health Initiative for having me here today. It's truly an honor and pleasure. So here's a quick overview of what we're going to cover. We're going to go through really defining what health equity is, why it matters, what are the root causes of health inequities, and how do we advance health equity overall, generally speaking, but also as it relates to the Accountable Communities for Health initiative. So what is health equity? Well, to define health equity, we really need to first understand what health is. According to the World Health Organization, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. The World Health Organization goes on to say that health is shaped by the conditions in which people are born, grow, live, work, and age. These are referred to as the social determinants of health. And this is critical to understand because health is a production of society and our conditions. It is, again, not solely about disease, but about the forces that create opportunities for all to achieve physical, mental, and social well-being. Now, as growing amounts of research show, over 80% of our health is shaped by factors outside of healthcare. As you see on the image to the left, 50% of health is directly predicted by our zip code or the neighborhood where we live, which shapes our opportunity for home ownership, quality of schools and education, jobs and income, and other community, safety, and environmental factors. If you look at the 30% in orange, that can be traced back to health behaviors such as diet, physical activity, smoking. However, it's important to recognize that even health behaviors and the choices that we make about our health are shaped in many cases by the choices we have in our communities and by those social determinants of health. And so then this leads us to a definition of health equity. I'll start with the World Health Organization definition. Health equity, according to this one, means the absence of unfair and avoidable or remediable differences in health among population groups, defined socially, economically, demographically, or geographically. Now, another definition by the Robert Wood Johnson Foundation, which aligns with the World Health Organization definition, but is a little simpler to communicate, particularly to mainstream audiences, is that health equity means everyone has a fair and just opportunity to be as healthy as possible. And Dr. Braveman and Robert Wood Johnson Foundation go on to say that health equity requires removing obstacles to health, such as poverty, discrimination, and their consequences that include powerlessness and lack of good access to all those social determinants of health that we just mentioned. Now, also important is to understand that when we undertake this work, we also want to be able to measure our progress and our outcomes as they relate to equity. And for this purpose, Dr. Paula Braveman says, for the purposes of measurement, health equity means reducing and ultimately eliminating disparities in health and its determinants that adversely affect excluded or marginalized groups. So I want to take a moment just to unpack what we've talked about and really highlight across these different concepts and definitions a few key principles. First is that understanding equity requires a commitment to fairness and justice. You saw that in the World Health Organization definition. It's part of CDC's definition of equity and the one we shared with Robert Wood Johnson Foundation. Equity is also an ethical and human rights principle. It is also both a process and an outcome. In other words, we work to advance equity through programs and interventions, while we also work to achieve equity and outcomes in our society. Equity also requires a focus on systemic causes of inequities, such as systemic racism, and addressing the social determinants of health. It really requires us to move upstream, and we'll talk a little bit more about this. And while equity is about everyone, it really requires a focus to improve circumstances and outcomes of historically excluded and marginalized groups. Now, these will vary, historically excluded and marginalized groups, based on the community where you are working and partnering with. But most often across our state, across the country, marginalized groups include people of color, particularly Black, Hispanic, Native American population groups, people living in poverty, people with disabilities, lesbian, gay, bisexual, transgender, gender diverse individuals, and you see, others in this list here. I also want to emphasize the fact that equity is not the same as equality. As you see in this image from the Robert Wood Johnson Foundation, on top, equality is giving everyone the same resources, or in the case of this image, the same size bike, regardless of age, size, and physical abilities. While doing so creates equality, we really haven't addressed the fact that everyone doesn't have the potential to ride this bike and get to their destination. So equity, which is the bottom image, means giving people resources according to need so that they can achieve their true full potential. In this case, giving each member of this family a different size, shape bike according to age, size, physical ability, to ensure that each is fairly able to reach their destination. I also want to make a distinction between health disparities and health inequities. This is very important as we go about this work, and particularly as we get into measurement, accountability, and so forth. Health disparities are differences in health outcomes and their determinants. These differences don't necessarily have to be unjust or unfair in nature. For example, if we consider rates of coronary heart disease, and we compare individuals under the age of 20 and those over the age of 60, you would expect to see a disparity or a difference in these two population groups, because there is an association between coronary heart disease and age. That is a disparity, but it is not an avoidable, unfair, or unjust difference. And that is what health inequities are. These are differences or disparities that are preventable, they are unfair, and they are unjust because of underlying inequities in our opportunities and resources. So why does this all matter? Well, as my children have come to learn more and more about the work that I do and what health equity is, my elementary school one would say, well, Mom, that's the right thing to do. In other words, we have a moral obligation to ensure fair and just opportunities for all. After all, our nation was founded on a principle of liberty and justice for all. And our commitment to equity is part of that covenant. Equity also matters because it saves lives, it helps our economy, it protects national security, and the fact that each of us is inextricably linked. And really, I turn to Dr. Martin Luther King Jr.'s quote, "Injustice anywhere is a threat to justice everywhere. We are caught in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one directly affects all indirectly." And I would say the times we're in amid this COVID-19 pandemic, this could not be further from the truth. So again, why does health equity matter? Well, here are some statistics I'm going to share. The United States spends more than any industrialized country on healthcare, roughly twice the average cost of other countries, and more than twice the cost of health spending of Japan, the country with the best health outcomes. So here are, these are per capita spendings that you see here. Now, you would think that would translate to some really good health outcomes. Well, that's not the case. Despite this high spending, the US ranks toward the bottom internationally on health outcomes as we compare ourselves to other high income countries. So these data here are for infant mortality. As you can see, the US has one of the highest rates among other high income countries. And this plays across the board on health outcome measures. I've got another example here, life expectancy, where again, we rank toward the bottom, ranking 28th out of 36 high income countries. On average, an American can expect to live to just above 78 years. That is almost 3 years younger than our neighbors and friends across the border in Canada. And these high costs and poor outcomes that we experience are in large part due to large and persistent health inequities in the United States. These inequities begin at infancy and play out through the life course and have persisted for generations. And so what I have here are some data on average life expectancy for Black and white Americans for select years starting 1950 to 2017. And I'm comparing Black and white because I was really able to go far back over the years to gather some of the data to bring home this point. The good news is that over the last 70 years, average life expectancy has improved for both population groups, whites and Blacks. And we have narrowed the gap as well between white and Black Americans to where now the life expectancy gap between the two groups is about 4 years. But it is still troubling to know that that gap exists, number one. And number two, it's troubling to also know that even though white Americans are doing better than their Black counterparts in this country, they are still performing far poorer than their international peers. So we're still not reaching our true potential as an entire country while also disenfranchising, and continuing to exclude some of our marginalized populations along the way. And these inequities play out profoundly across the state of Texas by race and place. So I thought it'd be nice to just share with you some of the, and you're probably familiar with this, life expectancy data for the 6 counties where the Texas Accountable Communities for Health initiatives are located. And so graphed here again is average life expectancy. And what we find is a few key findings. Number one, the life expectancy varies profoundly here again, depending on what county you're in and also by race. Just across these 6 counties, there is a 20-year life expectancy gap, where Hispanic residents in Williamson County live on average to 91 years, and Black residents in Gregg County to just 71 years. And the second key takeaway from this is even within groups, wide variations exist across the counties. So if we look at white Texans, for example, across these counties, their average life expectancy varies by 8 years. For Black Texans, it varies by 15 years across these sites. And for Hispanic Texans, it varies by 10 years across these sites. And these inequities play out, as you're familiar, across the board, regardless of what health outcome measure we're talking about, be it obesity, diabetes, high blood pressure. We find in particular Black, Hispanic, in some cases multi-racial population groups have some of the most disproportionate poor outcomes. So health inequities come with a heavy price tag, as the work out of Episcopal Health Foundation and others have shown. In 2016, it cost Texas $4.6 billion in excess medical spending and in lost productivity. In terms of lives lost too early among racial ethnic minorities, the cost to our state was $20 billion. Episcopal Health Foundation recently updated the study using 2020 numbers, And they found a 60 to 70% increase in excess medical spending and lost productivity since 2016. They also found that inequities in 2020 cost our state $7 billion in combined excess medical and lost productivity, as well as $23 billion for lost life years. Importantly, the report finds we also would have had 5,000 fewer COVID-19 deaths if Black and Hispanic residents had the same mortality rates as white residents. So there is a huge human economic toll of these inequities, and this is really why it matters. And so shifting the paradigm requires an understanding of the root causes of health inequities. For too long, we have focused on and invested in the medical model, that is, addressing behaviors, chronic disease management, treatment, and so forth, really addressing healthcare within health systems at the more downstream level. While this is necessary, we have come to learn that the medical model is truly not sufficient for producing health and health equity. And extensive work by the World Health Organization and researchers globally have shown the importance of moving upstream to address the structural and social determinants of health. So the framework you see here is adapted from the Bay Area Regional Health Inequities Initiative framework, which builds off of the World Health Organization framework as well. And collectively, what these frameworks show is that health behaviors, health outcomes are shaped by the social determinants of health, that importantly are shaped even further by structural drivers of health. These include our laws and our policies within our and across our institutions, but even those themselves are shaped by ideologies, by narratives, by strongly held beliefs, whether it be belief in hierarchical systems that shape and the laws that shape then the conditions in which we live and those downstream health outcomes. And so this is really important to recognize as we tackle work around health equity. In particular, we recognize the role that systemic racism, in particular in racial hierarchical systems and thinking, have created. And so this leads me to the Groundwater Approach, which is something the Racial Equity Institute has created. And it's really helpful to understanding in particular racial and ethnic health inequities in our society. And what this approach really attests to is the fact that we live in a racially structured society, and that is what causes racial inequity. And they say it plays out in three ways. If you look at the data, racial inequity looks the same across systems. Whether we talk about health, education, housing, it's the same racial and ethnic groups who are systemically disenfranchised and impacted. Number two, they say socioeconomic difference does not explain the difference in these racial inequities. And number three, they say inequities are caused by systems. So we've got to take a systemic approach to address them. So to bring this point home, I've got some data from our Health Opportunity and Equity Initiative. We just rolled out the data dashboard. It's available at hopeinitiative.org. And what I've charted here are data for the state of Texas by race ethnicity for a range of social determinants of health. And what you see across the board is that Hispanic and Black Texans persistently face the greatest barriers, whether you talk about home ownership, income, education, the opportunity to live in low poverty neighborhoods, or healthcare access. It's the same populations. And if you recall the data I shared earlier, those are the same populations facing the greatest inequities in health and health outcomes. While education helps, it does not eliminate racial inequities and opportunity. And so again, I'm drawing and sharing some data from the HOPE initiative. These are homeownership data at the national level. They're presented by race, ethnicity, and by education. And a few key important points here. At every level of education, even among those with a less than a high school education, white Americans have the highest rate of home ownership. So those are the dark blue lines or bars that you see across the board. Now, even at the highest level of education, So college graduates, for example, white Americans continue to have higher rates of home ownership than all other people of color. And the third key takeaway is for households headed by college graduates, so Black, Hispanic, multiracial Americans who have a college education, they still have lower rates of owning a home than white Americans with less than a high school diploma. As we'll see in just a bit, these outcomes in home ownership are not by accident, but are driven by a long history of discriminatory housing and lending laws and policies we've had in place that continue to have an impact today. So that was kind of, education really doesn't remove inequities in opportunity. It also doesn't eliminate inequities in health. So this is an example of infant mortality. Again, we find at every level, communities of color still have, poor outcomes on infant mortality. And even at a college education level, what we find is that college graduate Black mothers have infants and infant mortality rate that is similar to white mothers with less than a high school diploma. And scholars point to the fact that there are much larger forces beyond what we would call education, socioeconomics, individual achievement at play. What's really at play here is racism as the underlying root cause. So what is racism? Well, I'm going to rely on Dr. Kamara Jones's work. She's a physician, leading public health scholar on racism. And she defines it as a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race, that unfairly disadvantages some individuals and communities and unfairly advantages others, and it saps the strength of the whole of society. This is a really dense definition, so I want to unpack a few key points. First is that racism is a system. It is a system of structuring opportunity. And that's critical to understand because sometimes when we get into these difficult and complex conversations about racism, we start to feel defensive, like something is wrong with us individually. And we have to recognize that even at an individual level, racism is influenced by systems and structures that have shaped our ideologies, that have shaped our education and the experiences that we've had. And so understanding this as a system is critical to really beginning to driving action around it. Second is that it's a system that unfairly advantages some and disadvantages others based on race. And the idea that race is not a biological factor, but a social construct. And the third is what we just saw with the data, that it saps the strength of the whole of society, where we are not even as a nation able to reach our true potential in terms of health outcomes when we compare ourselves internationally, and the cost burden that this has on us as well. So racism plays out at several levels. Most commonly, I'm sharing kind of the four commonly levels as it plays out. At the individual level, really individual stereotypes, implicit bias, prejudice that we hold as individuals. Many times these are unconscious, these are unintentional. It is, very human to hold and have biases. It doesn't make us a bad person in any way. But it's really once these biases start to present in our actions is when it turns and moves to that next level of interpersonal racism. And that is the expression of bias and discrimination between people. This can present as lack of respect, which comes up between patient-provider interactions. It can play out as avoidance or suspicion of specific groups being dangerous. It can even play out as dehumanization, as we've seen in cases of police brutality. Then as we continue to move further upstream, there's institutional and structural racism. Institutional racism is built into the policies and practices we have within our institutions and organizations. And structural racism is when the racism really spreads into the law of the land, into our structures and systems. And that's really what we're tackling in present day America is the effects of this legacy of policies that we've had in place that continue to have an impact. In fact, scholars say that institutional and structural racism have had the most profound impacts on health. And as an example, I'm going to share with you, some data and information from the city of Houston and the Houston area, which is where I'm located. As scholars say, racial residential segregation is really one of the most profound examples of structural institutional racism that continues to shape opportunity. The map that you see to the right is a 1930s map of the city of Houston, generated by the Federal Homeowners Loan Corporation, which generated these maps for over 200 cities across the country. And what they did was they redlined certain areas. And so these are shaded in red in this map here. And these areas were considered hazardous and areas where loans would not be provided to white families for home ownership. They were considered hazardous for many reasons: land use, housing age, and other reasons. But importantly, also because of the concentration of people of color in these communities. And so while the Fair Housing Act of 1968, ultimately undid this discriminatory policy, the effect that this had has been multi-generational over time. If you look at just what it's done over time within our own Houston area, I'm highlighting two areas here. There's the River Oaks area, where life expectancy for white Houstonians is 92 years. So this is where Senior Bush and their family and housing is located. But when we come to that Fifth Ward area, which was redlined, this today is home to nearly 96% of people of color, predominantly Black, Hispanic. This is also one of the first sites, cancer cluster sites, that has been identified within our city due to carcinogenic exposure from industries over the last 80 years. And so life expectancy, in particular of a Black Houstonian living here, is 68 years. That's 24 years less than just a few miles away in the River Oaks area. So what this phenomena has done, and it affects many communities across our country, is it's confined communities of color for generations in areas of concentrated poverty. It has deepened income and wealth gaps, and it has really created difficult conditions for opportunity and access to basic life opportunities, healthcare, and really affected health outcomes in these communities. And I also want to point out that beyond the community impact, that racism, bias, discrimination also has an impact directly for communities of color in terms of poor quality of care that translate to poorer health outcomes. It also leads to chronic and toxic levels of stress that increase risk for heart disease, stroke, cancer, substance abuse, depression. I mean, the list goes on for chronic conditions among people of color. So when people say that systemic racism is a public health crisis, this is exactly the reason why, because it has disenfranchised people of color from opportunity within their communities, and it has a direct impact on health and changes the physiology as well of individuals that have to experience this on a day-to-day basis. So how do we address these complex issues and really work to advance equity? In this section, I'm going to share some frameworks, ideas for you all to consider as you go about your own journey. The first model here, these are guiding principles from Dr. Kamara Jones, who says there are really three key priorities we need to focus on as we work to advance health equity. The first is we must value all people equally. This requires ensuring our policies, programs, and interventions are designed to benefit all people. It requires ensuring individuals and voices that need to be at the decision table are present. Secondly, recognizing and rectifying historical injustices. working to identify the history of injustice within communities, who has been impacted, and how is that history manifesting in added and continued disadvantage in the current times. Involves engaging with, listening to, learning from our communities, as well as collecting and documenting disaggregated data on health and the social determinants of health. And finally, Dr. Jones emphasizes the need for providing resources according to need, which is that image that I shared, with the bicycle. That's an important premise of health equity altogether. Another model is a triple aim of health equity. And I thought this was another way really for us to emphasize what are key priorities as we tackle work around health equity. I'll start with saying, the first and foremost is expanding our understanding of what creates health. This is why when I started with my definition of health equity, I said it's important we've got to widen our horizon to understand what health is. We've really got to help and work with our elected officials, leaders, and decision makers to begin to understand this phenomenon and really embrace it in the work that we're undertaking. The second is implementing and building a health in all policies approach with health equity as the goal. And the third is strengthening the capacity of communities to create their own healthy future. So that means ensuring they are engaged and empowered to co-lead, co-design initiatives intended to affect their conditions and livelihoods. Also important is advancing health equity across sectors, working through cross-sector action at multiple levels. I shared this model earlier. It's going to require healthcare interventions, but it's also going to require addressing social needs, such as is happening through some of the work you all are doing around social needs screenings and community referral and connection to resources. But it also requires continuing to move further upstream to address the social determinants of health. And what that requires is cross-collaborative efforts with our communities to invest in and really address basic social determinants of health needs. And even further upstream is working to raise awareness, education, to change mindsets and narratives, as mentioned. In addition to that, I really want to, hammer home the point that health equity is really a journey, and it's a journey at multiple levels. It starts with us as individuals, really having a self-awareness of our own biases, and this requires, listening, learning, and understanding from others. We can also, take advantage of different assessments and tools and trainings that are out there. There is an implicit bias online training that's available, the Implicit Association Test, IAT. There are resources, an online course that in particular I like is Kirwan Institute's Implicit Bias module. Cultural competency tools that exist. For example, Think Cultural Health provides a menu of resources. So there's a lot that we individually can do as we're on this journey to ensure, we are well prepared as individuals, as leaders in the roles that we're playing. In addition to that, if you're familiar with Dr. Daniel Dawes' political determinants of health, he says a primary political determinant is voting and civic engagement. And so that's another way for us individually as we're on this journey to really engage and advance equity priorities. Organizationally, it really starts with having and valuing health equity as a shared priority that then is really reflected in our mission, vision, and all that we do. Much of this work can also be driven by conducting internal equity assessments and then taking those learnings to really inform then what are the kinds of policies, trainings around diversity, equity, inclusion we would need to have in place. Engaging communities, as I've mentioned, is critical to this process. And data, as Dr. Dora Hughes will get into, is critical too to monitoring impact, evaluating impact as well. And then finally, at the community level, a whole host of efforts around cross-sector collaborative work, such as you all are undertaking and leading through your initiatives and ensuring community-led, community-created targeted interventions and solutions is critical. But again, we've also got to move even further upstream to really to think through how can we inform and drive policy and systems change ideologies and mindsets to really embrace equity as a priority um, uh, within our society, as you know, we've been pleased to see the Biden administration has been doing.
So Nadia, this is fascinating information, and you've given us a lot to digest here. What is most important for the Tachi site when thinking about how to advance health equity in their own communities? What would you, where would you sort of point them as a starting point?
Yes, absolutely. So actually, you know, what I did was I pulled together some of the key takeaways from the previous slides that I presented to share maybe a little bit more of a condensed version of what might be priorities for accountable communities of health initiatives to take on. And this is adapted from Annie E. Casey Foundation's 7 Steps to Advance and Embed Equity. And what I really like about this approach is that regardless of where you are, you know, some of you might be far ahead in your equity journey, some may be somewhere in the middle, and some may just be getting started. But critical to these efforts is number one, ensuring that there is a shared vision, understanding, language, even a definition around health equity that our accountable communities for health initiatives have embraced. The second is really thinking about community engagement as a way to co-create, co-lead some of this work so that we're not just checking a box, but we're truly embracing and engaging in meaningful, authentic ways. Data, as I've mentioned, is critical to identifying, prioritizing, and monitoring inequities. And related to that is conducting systems level analyses of root causes of inequities. And there are many tools out there that are really helpful for this. There's the fishbone framework that helps you understand, okay, these are the inequities in our communities. Well, what's driving it at the downstream, midstream, and upstream levels? And then that can inform then number 5, which is identifying strategies, targeting resources, and then moves into the entire cycle of, well what impact are we having across you know, different communities that we're targeting, and monitoring that again, which I know Dr. Hughes will get into. I also want to share that this is a framework actually pulled directly from the Accountable Communities for Health resources, and want to emphasize that as the ACH sites go about this work, it's critical to recognize that equity is not just a siloed effort, that it is a principle and priority that must be integrated across all the essential elements of ACHs, whether it's governance, leadership, shared vision, continuous learning, data systems. And so I've got some little examples here that I've mapped out that I thought might be helpful to the sites. I won't go into detail because I've mentioned much of this in the previous slides, but certainly there for folks as a reference.
So Nadia, I know that you and your colleagues at the Texas Health Institute are doing a lot of work in the area of health equity, trying to advance this in the state of Texas. Can you tell us a little bit more about some of that work, and specifically, how might you be able to help the Tachi sites in the days ahead?
Absolutely, absolutely. So I don't know how many of you know about Texas Health Institute. We are an independent, nonprofit, nonpartisan public health institute with a mission to advance the health of all. And I will say that we've been on a health equity journey for you know, many years, but really our explicit journey started in 2010, and I've been around the institute since this work launched and got started. And a lot of that work was externally facing, where, you know, we focused on developing guidance on diversity, equity to integrate into preparedness, response related work. We did a lot of work around the Affordable Care Act and creating health equity assessment tools to help organizations, you know, assess their readiness capacity. So there's a lot of tools that were developed. The Health Opportunity and Equity Initiative is another national level effort. We just rolled out a data dashboard that provides equity metrics for communities to consider as well. And then, we've also led considerable amounts of community engaged led equity and social determinants based work as well. I will say that all that work, mostly externally facing, it wasn't until 2018 that we realized, you know what, we need to look internally as well, and ensure that our own policies and the work that we're doing is in alignment with what we're telling others to do. And so we're now on this combined internal external journey that I would encourage all accountable communities for health initiative sites and organizations to really embrace as well. Because equity is not just about what happens externally, we've got to internally walk that talk as well. So in 2018, we relaunched Centering Equity in our mission, our vision, our objectives. Something that I think would be great for our accountable communities for health and exercise to take on. Then we continued down that path and really elevated equity across all that we do. We elevated it in terms of financial commitment, as well as elevating it to leadership roles so that we can build accountability toward it. And where we're at right now is really conducting a series of internal and external assessments to understand, again, underlying capacity, resources, barriers, where we're doing well, where gaps are. All of this, we hope, will then inform a strategic plan for us, but also for us as a partner within the state of Texas to continue to engage our partners and really advance health equity and ensure every Texan has a fair and just opportunity for health. I will close just very quickly by sharing the Hope Initiative dashboard, hopeinitiative.org. And the reason is because, again, this can really help sites set equity goals for population health and social determinants of health related measures, and provide kind of a framing for how you go about monitoring some of that progress and some of what Dr. Hughes will get into as well. In closing, a quote that really resonated with me from Dr. Marcella Nunez Smith, who is the co-chair of the current White House COVID-19 Health Equity Task Force. She says health equity work is about, really, you have to show up, you have to listen, you have to be humble with equity work, and communities are experts in what they need. Thank you so much, Keith, and Accountable Communities for Health effort. It's been a pleasure being here. This is my contact information, and I really look forward to the ongoing engagement and work with you all.
Well, thank you very much, Nadia. That was an excellent presentation. I love your slides. You have an expertise there that's far surpassing anything I could ever hope for. We will certainly look forward to hearing more from you and Dr. Hughes in the upcoming knowledge sharing forum in a few weeks. But I will thank you again and hope you have a wonderful rest of the day.
Thank you so much, Keith.